You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for April 3rd, 2020. This week, it's COVID-19 again. I usually say thanks for listening at the end of the podcast, but in these extraordinary times, I want to start this week by saying thank you. I appreciate your support. When I recorded last week, there were 85,000 cases in the U.S. Today, there are nearly 250,000 cases. It is a threefold increase in just 7 days. Now, you might say that this is due to an increase in testing, but I do not think so. It's because of the deaths. A week ago, U.S. deaths were 1,200. Today, they're nearly 6,100. That is a five-fold increase in just 7 days. Now, if this five-fold increase were to continue, we'll be at 30,000 deaths next Friday. And after that, well, you get the picture. Now, it's just a number, but last evening, the total coronavirus cases worldwide tipped over 1 million. 1 million. Now, one of the things my astute son, who was home from college, pointed out to me is that while there are 1 million cases, there are only 200,000 that are resolved. That leaves well more than 500,000 cases unresolved. This is important because while we all believe that the denominator will expand and that will make the case fatality rate lower, there is also uncertainty regarding the numerator. Remember what the ICU docs have taught us. Once these patients are on a vent, they stay on a vent for days and weeks. So in the coming weeks, we could see a significant increase in the numerator. But another comment on the numerator. My friend Andrew Foy from Penn State reminded me about the potential problems with misattribution of deaths from COVID. It may be that many of the deaths labeled as from COVID are actually deaths with COVID. Well, make no mistake, I do not know, but it seems wise to think about COVID numbers not with point estimates, but with error bars. First thing, this week, I want to start by reiterating my admiration for those on the front line. Our hospital now has dedicated COVID units, both in the ICU and floor. It gives me pride to round on these units. You feel a sense of reverence, respect, like in church. Again, I am a mere interloper, a consultant who comes and goes with minimal exposure. Those who work entire shifts on these units bear the brunt of the risk. Before COVID, these were just regular docs and nurses and respiratory therapists. They were people that I saw every day. But from now on, the people who face the highest risks at a time when we don't understand exactly how this virus is transmitted have earned extra respect. I will remember who they were, and I hope administrators and leaders in each hospital system also remember these frontline people. Now, another group to highlight again are my emergency department colleagues, the docs, the nurses, techs, respiratory therapists in the emergency department. This is where sick people present, but of course, the infirm do not come in with a sign saying they are positive for coronavirus. One thing I have learned from this last week in taking care of patients is that patients with COVID-19 can present in many different ways. Not all of patients come with classic cough and fever. That means nearly every patient encounter presents risk. And then I want to shout out to the primary caregivers. Here is my worry. While the sickest patients may present to the emergency department, and the emergency department knows this and is mostly ready, many patients, less ill but equally infectious, will seek help from primary care docs. PPE is clearly in short supply in hospitals, but I wonder, have we given the frontline primary care clinicians enough protection? Now, in writing this podcast and in writing columns, I use my dictionary a lot. This week, I looked up the word hero. Quote, a person who is admired or idolized for courage, outstanding achievements, or noble qualities. The frontline workers at the bedside fulfill this definition. And kudos to my colleagues at the Heart.org and Medscape for keeping a memoriam for healthcare workers who have courageously died in the line of duty. Second topic today is that my mental state has improved. I hope yours has too. In the first few weeks of this crisis, I felt as if I was aging every day. I took my temperature often because the mental anxiety would give me these flush sensations and headaches. Well, these are now gone, but I still vacillate on where we're going. If you listen to Dr. Paul Offit, perhaps one of the world's most accomplished virologists, or John Unides, not a virologist, but clearly an expert in epidemiology, you get the sense that COVID will not be a 1918-like disaster. You feel reassured. But then I read and listen to Dr. Mark Lipsitch and Michael Osterholm, who study viral pandemics, and think, oh my, if it is really true that 60% of the U.S. population will become infected, and it is also true that the case fatality rate is even 0.5%, that means we could see millions of Americans die. So why is my mental state better? I think because I'm resigned to getting this infection. I guess I cannot stop going to the hospital. I'm a doctor. I want to be there. And my understanding of the data out this week and in previous weeks are that the virus is everywhere. For instance, we already have cases, like I am sure you have and have been described previously, of patients admitted for something else and then later testing positive. Well, this means before these patients were put into isolation, they were spreading virus everywhere. What's more, studies now show that the virus is in the air, on the air ducts of patients' rooms, on keyboards, mice, and possibly even packages coming from Amazon. And even if you can avoid infection in the next week or month during this surge, can you really avoid it for a year or more? And I can't stop thinking that there is also a large treasure in recovery from this infection, and that is immunity. Once you're immune, you're free to return to normal. Now, some have suggested that immunity is not guaranteed after infection. But if that is true, the human species is doomed, and we ought to be opening our best bottles of Bordeaux. No, I'm not saying I'm going to go in and lick the counters of the COVID unit. I am taking sensible precautions. I assume that I am infectious mainly to protect others. Third topic, this leads me to the issue of healthcare workers being more prone to serious illness. The first question I ask, is it real? I've asked a number of smart people whether they think the anecdotes of younger, healthier-appearing clinicians getting seriously ill and dying from this virus is a real phenomenon or just a result of media coverage. For instance, what would it look like in years past if every time a healthcare worker died of influenza or RSV or a bacterial infection, the Washington Post or New York Times wrote about it? It would look scary. But no, most of my smart friends think the risk of more serious illness in healthcare workers is indeed a real phenomenon, and I do too. But then the question is why? Why would we be more susceptible? Plausible reasons might be that we get a higher dose of the virus at the time of infection. Another cause could be repeated exposures. Another could be that sicker patients shed virus more readily. The influential writer Dr. Sid Mukherjee, writing in The New Yorker, pondered these possibilities. While he stated clearly that we need more study and that there was uncertainty, his message was that viral exposure is akin to radiation exposure. The more you get, the more likely you are to get very sick. So I think, yes, the precautionary principle holds here. It makes proper PPE a vital issue, as it surely reduces the risk of having a big exposure. I wish we knew more about the best way to protect ourselves, and I think this information will come with time. Fourth point, I'm trying to keep a tally of lessons learned from this crisis, and here I have to point you to Dr. Eric Topol's piece this week. Dr. Topol makes a three-pronged argument that U.S. public health leaders betrayed healthcare workers First, in the lack of testing, which let the virus spread silently. And then we sent clinicians into war without ammo. And finally was the deception that young and healthy people can't fall ill. His conclusion was clear. Quote, "The handling of the COVID-19 pandemic in the U.S. will go down as the worst public health disaster in the history of the country. Perhaps what we in the medical community will remember most is how our country betrayed us at the moment when our efforts were needed most." So one of the lessons I think we must take from this is our need to advocate for ourselves. When I do telehealth visits, many of my patients thank me for what I do, as if I am a soldier or something. That's different. Healthcare workers have always enjoyed high levels of public trust, but it's reached a zenith now. Another thing COVID has gifted us with is an infusion of leadership from clinicians. At my place, and probably yours, there are groups of doctors that are leading COVID policy decisions. This was necessary. While administrators know numbers, clinicians know how to care for the ill. And that too is different. In a COVID world where no one knows the way through the forest, bedside clinicians need to be on point. So what I hope happens from this tailwind of public goodwill and our taste of leadership will be that it brings back a degree of professionalism amongst those who deliver care at the bedside. Fifth point, COVID has amplified the already present and utterly destructive phenomenon of intolerance of ideas. Science cannot function properly in this setting. Two examples. This week, the intolerance surrounds the controversy of mask wearing. Now, I'm not talking about mask wearing in hospitals. The ubiquity of the virus now makes it obvious that wearing a mask during patient care in the hospital is beneficial. The vacillation on hospital mask wearing was never about the benefits, it was always about supply. This week, I was struck by the public debate about the benefits of public use of masks. Medscape has a highly discussed piece that I'll cite, and Ed Young from The Atlantic also wrote on it. In short, in many Asian cities and countries, mask wearing in public is viewed as fulfilling a moral contract for public safety. This has not been so in North America, though it has moved to acceptance in the Czech Republic and Austria, two countries that now require citizens to wear masks in public. Many public intellectuals think that we should adopt the Asian way. Some of their arguments are strong, others are weak. Strong arguments are that masks in the public foster the greater good because you're helping others by reducing the spread of the virus. And another strong argument for public masks is that benefit is not dichotomous. While masks may not be universally preventive, they probably do reduce transmission somewhat. But a very weak argument for public masks are that countries with masks have flattened the curve. This is weak in the same way that observational data is weak, confounding factors. Countries that flatten the curve have done many other things besides public wearing of masks. The problem, the intolerance I noticed, is the vitriol when others make an argument or point out the weakness of wearing public masks, that they are difficult to use properly, that they may distract from other important measures, etc. I tweeted a reasoned piece without endorsing it, just tweeted it, and felt the ire of intolerance. In the Atlantic piece, the writer Ed Young used hundreds of extra words and all his skills as a writer to present the arguments without bringing the scorn of intolerance. The second area I see intolerance is in those who discuss the harms of our interventions. I'm going to risk it, and here goes. While this is a major pathogen, one that demands our attention, you cannot deny that we are causing direct harm to millions of people right now. Yesterday in the news, it was reported that 10 million Americans lost their job. The problem is especially acute in the United States because so many of these millions get their health insurance through employment. Losing health insurance during a pandemic is frightening. So think about this in terms of a medical treatment. COVID is the problem, and our current treatment is shutting down the economy. This will cause harm. It will ruin people's lives. Now, against that certain harm is the probability of benefit, of flattening the curve. I say probability because the treatment is based on models, which even the modelers say are likely wrong. Now, make no mistake, I am not one of those people like the Fox News people who say we should go back to having major sporting events But I also think it is unkind to dismiss concerns over the ruin of millions of people's livelihood. I hope that we see an increase in tolerance for those who speak about the harms of our choice of therapy in this pandemic. Final topic, 3 short bits on cardiology. The virtual ACC and the ischemia trial were published this week. Medscape has excellent coverage. But I'm sorry, in this time of grieving, it seems irreverent to discuss these issues. However, there is much to learn on how coronavirus affects the heart. Doctors Mark Dweck and Nicholas Mills in Edinburgh, Scotland, asked me to mention a 2-minute survey on transthoracic echo imaging in affected patients. This survey is a joint effort of the ESC and European Association of Cardiovascular Imaging. You can find a link on their Twitter page, and I will reference it in the show notes of this podcast. This is one of those public efforts to help foster knowledge faster than any journal could. They're interested in how COVID affects the heart. Plus, I have to say that I have a soft spot for the Scott Heart investigators. Despite being a vocal critic of this study, this group treated me with kindness and support when I visited Scotland, and for that, I thank them. So that's all for this week in cardiology. As always, I'm grateful that you listened. Thank you, and remember, if you like this podcast, please subscribe on the app, give us a rating so other people can find us, and tell your friends. Until next week, please stay safe. This is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.